Finding your way with ocular melanoma, join me, host Tara McCannell, as I share with you everything I know about ocular melanoma. I hope you will learn, grow, get your questions answered, and be motivated to live your best life. Visit my resource page, sayhart.com/ocular melanoma. That's SEYHART/ocular melanoma for more content, support, to find my new handbook for patients and families, and also to explore other support that I personally offer. Today, I'd like to talk about a topic that comes up frequently, especially at the time of diagnosis and even after diagnosis. Should prognostic biopsy results change your treatment plan? First of all, what composes your treatment plan? There are really two main things that are part of your treatment plan. One is how you treat your eye, and two is what you do to monitor the rest of your body. It really comes down to those two things. What are prognostic biopsies? What results do we get when a prognostic biopsy is performed? A prognostic biopsy is a test that tells us what your risk is of this cancer possibly spreading in the body. That means your prognosis. How are you going to do with this? If you do well with ocular melanoma, we treat your eye and the cancer does not return in the body, in the eye, anywhere. The eye is treated and you're done. In that situation, we call that good prognosis. When you have a high risk prognosis, and sometimes people call this a poor prognosis, it means that the risk that the cancer could come back in the body somewhere else is high, or that there is a higher probability that this could happen. So, prognostic biopsy results have evolved over the last several years. We didn't know much about prognostic biopsy until 15 or so years ago. People were diagnosed with an ocular melanoma. It was treated, and then we monitored. We monitored the liver, you had scans, and we kept a close eye on things. And if something came up, we would deal with it. But since the evolution of prognostic biopsy, we have a way of sampling the eye tumor and testing the sample for markers. What can you test an eye tumor for? Well, we've always been able to test tissue, and usually that is through pathology. What is pathology? Pathology is really just telling us what it is. So if we're not sure of something, whether it's in the eye or in the body, pathology can give us clues. Cells are taken, inspected under the microscope. Sometimes those cells can be stained with certain tests, and then we can get an answer as to what the tissue is. This is very common in other parts of the body, but for ocular melanoma, we usually don't need to have the pathology because diagnosing ocular melanoma comes from clinical experience. That means the doctor examines you, I should say the ocular oncologist evaluates you carefully and makes a decision on what you have based on their own clinical experience. The reason we have been performing biopsies in the last decade plus is because of the evolution of prognostic markers that we have discovered are within the tumor cells of the eye. And what we have found is that there are markers that are associated with low risk for metastasis and markers that are associated with high risk for metastasis. Please note that these markers have nothing to do with what is going to happen with the eye cancer, with your ocular melanoma that is initially diagnosed. If you are diagnosed with eye cancer and ocular melanoma, that melanoma in the eye, by definition, is a live cancer. And those cells divide and grow exponentially. So you may start off with a little lump that is cancer, and as it grows, the rate of growth will increase. So if you don't treat your ocular melanoma, that mass that tumor, that cancer, will eventually outgrow the eye. It might not happen overnight, but as time goes by, cancers anywhere in the body tend to grow, and ocular melanoma is no exception. We don't have ocular melanoma of the eye that remains stable and doesn't change. Ocular melanoma will eventually grow, affect the vision, start to damage tissues in the eye. And in very advanced cases, if that cancer is not treated, the cancer will overgrow the eye, and your eye can become painful, blind, and it will become very difficult to treat. And you will be faced with being in a painful emergency situation where all we can do is take out the eye. We never want to be in that situation because early detection, making a diagnosis promptly, can completely avoid that. It can completely avoid even needing to have the eye removed. So let's go back to our initial question. Should prognostic biopsy results change your treatment plan? Should we take a biopsy of that eye cancer and decide if we should treat it or not? So the simple answer is no. And there are some ocular oncologists that take a biopsy when a person has an ocular melanoma, and then based on whether it's high or low risk, may or may not decide to treat you. So if you don't get treatment, the doctor may just decide to monitor you. Let me give you an example of what happens in some cases. And it's important that you know about this so that you can ask questions to your doctor if this should come up. You may be diagnosed with an ocular melanoma, and the doctor says, well, let's do a biopsy first before we decide to treat you. There are some problems with this. So what might happen is that a biopsy might be taken and a prognostic test will be used, not a pathology test. The pathologist will say, yes, this is an ocular melanoma, or this is something totally different. But if you have a prognostic biopsy, it's not going to tell you if it's ocular melanoma or not. It's going to give you some information back that is going to tell you whether this melanoma is a low risk for possibly spreading in the body or a high risk for possibly spreading in the body. What does that have to do with the eye cancer itself? Very little. In fact, I don't think it has anything to do with it. Whether you have your eye cancer in your eye treated or not should not depend on the result of the prognostic biopsy. I think what a lot of people who do this are thinking is that, well, if the test result comes back low risk, maybe I don't have to treat this cancer. Maybe I don't even have to venture into the possibility that this person might have their vision affected. If it's a low risk melanoma, let's just not do anything. We'll watch it closely. There are some serious problems with this. Number one, the cancer is going to slowly continue to grow. When are you going to treat it? When it's bigger? When the vision gets affected? I believe that as soon as we know it's an ocular melanoma, whatever the size, we must treat it promptly. That will improve your chances of seeing well, and it will also improve your overall mortality because the smaller ocular melanomas are when we treat them, the lower the risk that it may ever metastasize. That's the first problem. The cancer is still going to grow, regardless of what the prognostic biopsy test result comes back as. Problem number two, if you sample the tumor and it comes back as class 1, does that mean that that tumor will never metastasize? Unfortunately, the accuracy of prognostic biopsy results is not high. Yes, we have a lot of studies now correlating class 1, class 2 with low risk, high risk, but they are not absolute percentages. It's not 99.9% of patients with class 2 have X outcome, and it is certainly not 99% or 100% of patients with class 1 have X outcome. There's a range and it's variable. We already know that class 1 patients on prognostic biopsy can still get metastasis. And we all have many patients who have been found to be class 2 of the melanoma, and years have gone by and there is no metastasis. So prognostic biopsy isn't necessarily going to tell us for sure what is going to happen in your future. And number two, there is something called tumor heterogeneity. What does this mean? It means that the stuff inside a cancer is mixed up. When you look at eye cancer, we find that under the microscope and in the lab, that cancer is not uniformly, the molecular biology of all the tissue is mixed up. There's different types of cells. And we've already found that within a primary ocular melanoma in the eye cancer itself, there can be pockets of class 1, class 2, monosomy 3, disomy 3. So it really depends on sampling. You might just happen to get a sample of tumor tissue and it's class 1. We also have data that shows that as ocular melanomas grow in the eye, and we have histopathological and data with molecular testing that looks at prognosis, that as the cancer grows, the molecular profile can change. So when something starts off, for example, very small, we might biopsy it and find that it's class 1. And if you leave it alone and let it grow, and patients who have returned, lost a follow-up, they get rebiopsied and we find that it's class 2 or it's monosomy 3 as it evolves. So your prognostic biopsy result is nothing that is fixed in stone. So if we have something that is so variable, we don't know for sure that it means you're going to get metastasis or not. We might have sampling error, and the tumor might have different areas with different prognostic biopsy results. How can we use this test to decide whether or not to even treat your eye? So I hope you understand that component. And I feel quite strongly that if you are diagnosed with ocular melanoma, you need to get it treated, because the sooner you treat it, the less amount of radiation we need to use to kill the cancer. And if we don't have to use as much radiation, that just means that you're going to have fewer complications down the road, and that eye is going to do better and see better. But not only that, when we catch ocular melanoma when it's small, that means that your risk of metastasis goes down. The risk factor that is probably the most strongest in regards to whether or not a person will get metastasis is tumor size at diagnosis. So the sooner you treat that thing, the lower the risk of metastasis. Let's shift to using prognostic biopsy results in other ways. I've talked about how you might treat your ocular melanoma and what people might do with prognostic biopsy at the time of treatment. And I've told you what I believe is the best thing for your health and your vision. Treat that melanoma from the get-go. The prognostic biopsy result is not going to inform you and give you important information to weigh such a critical decision on. But what about after your treatment? Many people get a prognostic biopsy result, and then we have to monitor the liver. The eye's been treated. Part 2 of your treatment is keeping a close watch on your body. And how do we do that? We do that with scans. We monitor, we do scans of the abdomen, we check the liver, and many oncologists will do this every 6 months. The main medical oncologist with whom I work does a scan, does an MRI scan at 6 months, and then the following 6 months does a CT. So you get a mixture of MRI and CT scan, and you have a scan every 6 months. Now, what a lot of people are advocating is, why don't we use the prognostic biopsy result to alter the scan routine? For example, here's a melanoma patient who has a class 1 test result. Wonderful. Doesn't that mean that this person will almost never metastasize or have a very low risk? Why don't we just do scans of the abdomen for 1 year and then stop? Because that person's low risk. Let's no longer do the scanning. I'm saying that in this tone because I don't think this is a good idea. Remember what I talked about. Our prognostic biopsy results are not completely accurate. What if that person, we sampled on the biopsy an area of class 1, but the rest of the ocular melanoma was really class 2 and had high risk markers? And then we make a decision that's going to affect the rest of their life in terms of scans, and we decide no longer to scan them because we sampled a wrong part of the tumor. And if we had sampled a different part of the tumor, we have gotten high risk, and that person would be under closer surveillance. So what is the difference if you have close surveillance or your doctor stops? If you get metastasis of the liver and it starts small, you have so many treatment options. They might do a resection. You might have focal directed liver treatment. You might, with interventional radiology, you might be eligible for a clinical trial. There may be a new drug that is great for you because you have such limited disease. But if you decided from the beginning no longer to do the scans based on a biopsy result, you will miss that opportunity. And if you don't have scans at all and metastasis happens, if you start to get clinical signs of metastasis, your liver failing, becoming jaundiced or turning yellow because your liver stops working, there's very little you can do. So why would we use a biopsy result that has inherent inconsistencies? We might sample the wrong part, they're not completely accurate, and biopsy results can change as the cancer changes. Why would we change such an important, potentially life-saving follow-up strategy based on that? Here's what I recommend. I recommend that everybody be followed and monitored by their medical oncologist in a very similar way, regardless of what the prognostic biopsy test shows. But what can we use? What I think is important is considering tumor size at diagnosis. I feel that we have all the science, we have a lot of markers. This is an important area for continued study, but we still have to be cautious and not make big clinical decisions, treating your eye, monitoring the body for metastasis. We can't make big clinical decisions on information if it's a little bit inaccurate or has some inconsistency. We must continue to study these markers and see what they really mean. If a person starts off this journey with a very tiny ocular melanoma, so small that it might not even be possible to do a biopsy, that is a person who we might consider stopping metastatic screening early because their risk is truly very, very low when you have a very tiny ocular melanoma. And what about a person with a large ocular melanoma? Even if you come back with low risk markers, that's fantastic news, but let's not discontinue systemic follow-up just based on that. So to summarize, should prognostic biopsies change your treatment plan? I strongly feel that they should not. We need to look at everything, not just the molecular biopsy result. We need to look at the size of the melanoma. We need to look at how old you are when this is getting diagnosed. We need to look at your health. We need to look at all the things that we can control and change to allow you to live healthier and better. Thank you so much for your attention. I encourage you to ask me anything, reach out. I hope that I can answer your questions and help bring you up to speed with everything that I know in ocular melanoma.